So next speaker is Dr. Leslie Speed. She is a clinical oncologist from Leicester and will talk about radiotherapy.
Thank you and good morning everyone. So I've been asked to talk to you about the role of radiotherapy in treating desmoid fibromatosis. So this morning what I'm just going to do is to go through exactly what is radiotherapy. Some of you may be aware of it, either having had radiotherapy treatment yourself or know somebody else who's had treatment. It may be something new to some of you. So we'll just talk a little bit about what radiotherapy is. Why do we use it in fibromatosis? It's a little bit of the background to it. Then how do we do it? So what would actually happen if a patient was treated with radiotherapy? And then I've got some slides on a few cases where we've used radiotherapy in different situations. So what exactly is radiotherapy? So it's a very common treatment modality, particularly for patients who have cancerous tumours. And it is using ionising radiation, and this is aimed at destroying tumour cells. It does that by damaging DNA within the cell, and then when the cell comes to try and replicate and reproduce, it's unable to do so. So the cell dies essentially. And if we can do this for tumour cells, ultimately the aim is to shrink the tumour by killing off enough of the cells with the radiotherapy. It can be given in several different ways, but most commonly is delivered using X-rays and externally, so outside of the body. In certain situations we can give it internally, and that can be either through a patient swallowing a capsule, for example, or having an implant put into their tumour. For fibromatosis, it is particularly used externally with X-rays. So this is just sort of a little picture as to how radiotherapy works. So radiotherapy would be given to part of the body where the tumour is, and it can either cause cell death by directly damaging the DNA within a cell, causing this to break up and the cell undergoes cell death, or it can happen indirectly where the radiotherapy causes damaging particles within the cell, and they then cause the DNA damage and ultimately the cell dies. So as I said, predominantly we use it for patients with cancer, and about 50% of patients with a malignant diagnosis will have radiotherapy. That could be either before surgery to shrink their tumour, it could be after surgery to reduce the chance of it coming back by mopping up microscopic disease, or it could be used, for example, to manage somebody's symptoms if they were getting pain from a tumour. Of course, we use it for benign conditions as well. That's what we're talking about today with fibromatosis. But the idea of the treatment is the same. So we want the radiotherapy to kill or to damage the abnormal cells, be they causing a tumour or some inflammation. So for example, other conditions we use radiotherapy for would be thyroid eye disease. So if a patient has an overactive thyroid, they can get inflammatory tissue deposited behind the eye, and that can become uncomfortable and sometimes cause the eyes to bulge forwards. So radiotherapy would be given to kill off these abnormal inflammation cells and improve the patient's symptoms. And just some other conditions that we would use it for are as a keloid scar, so you have sort of an overreaction in a scar, which can cause a thickened skin, and also to treat a tumour of the nerves behind the ear, causing an acoustic neuroma. But obviously we want to focus about fibromatosis this morning, and as we've mentioned, this is usually managed by soft tissue experts, and that's usually within a team of people who are used to treating both malignant and benign soft tissue lesions. So why do we use radiotherapy to treat fibromatosis? We don't do it just because we fancy it. We think it might be helpful. We want to do it because there's some evidence to say that it works. So there's several studies. Unfortunately, they are all small studies because we know this is a relatively rare condition. There was a European study back in 2013 now, with it was about 40 or so patients looking at the role of radiotherapy in their treatment. And this showed that About 13% of patients who had an inoperable desmoid fibromatosis had a complete response to treatment, so their tumour disappeared completely. About 16% of patients had a partial response, so it means that the tumour shrunk due to the radiotherapy. 40% of patients had stable disease, so it didn't shrink, but equally it didn't grow on treatment, so that's reassuring. And only a small number of patients actually progressed during the treatment. Similarly, a German study looked at radiotherapy for desmoid tumours, and they reported about an 80% local control rate with radiotherapy. So this could be either stable disease or a shrinkage in the tumour. As a result of these and other smaller studies, then guidelines have been produced. We've seen some of these earlier this morning. So there is a European guideline published a few years ago now, which recommended radiotherapy after surgery or after medical therapy. And the timing of radiotherapy depends a little bit about where the tumour is in the body and how quickly you need a response to some treatment. And then more recently, there is a larger paper being produced looking at consensus guidelines as to how to treat desmoid fibromatosis as a whole, and radiotherapy is mentioned in there, supporting the use of it instead of surgery, if medical therapy has failed or it's not appropriate. And as a clinical oncologist, I go by the rules of the Royal College of Radiologists, and they also publish guidelines on how we should treat tumours, and their recommendation is for radiotherapy either for inoperable tumours or to consider radiotherapy post-operatively if there's a high risk of recurrence. So how do we do it? Most patients will already have had a period of surveillance, for example, or had some other form of treatment. Patients will have a course of treatment, so they need to come multiple times, and I need to make sure that somebody is in exactly the same position every day, so I know I'm accurately treating the tumour and avoiding normal structures near it. So we do that by doing a CT scan, and a patient needs to be in a comfortable position that's reproducible every day they come. So sometimes we need to immobilise the part of the body that has the desmoid in it, and we can do that in various ways, and this is just a couple of examples of how we might do that. So this is a piece of kit that would be on the couch where a patient would be lying, and their knees would be here, and their legs coming down here, and their feet kind of fit into this step at the bottom. So that ensures that a patient's legs in particular are in a still, comfortable position. If the tumour was somewhere such as in the neck region, then we might need to make this immobilisation shell, which is a plastic shell that fits over somebody's face and shoulders in order to keep them still. And again, so I know that they're in exactly the same position when they come every day for their treatment. There are other methods of immobilising different parts of the body as well. Sometimes we use something called a vacuum bag, which is a bit like a big bean bag that a patient will lie in. We then suck the air out of it, and it moulds around that part of the patient's body, again to keep it still and comfortable. So then we use all the images that we've got available. So people will often have many images during the course of workup towards radiotherapy. So they may have had an ultrasound, a CT scan, an MRI scan. We use all that information to work out exactly where we need to treat. So this is a CT scan of a tumour behind the shoulder, and this yellow area is where we believe the tumour to be. So that's what we can see as the abnormal tissue. But then we need to account for, as we've heard, these ill-defined edges. So it's not always very easy to see exactly where the tumour ends. So we need to allow what we call a margin to encompass these ill-defined edges, and also for a small amount of movement between each treatment. So the yellow area is where we think the tumour actually is, but the red area is where we need to treat in order to cover that area. So as I said, radiotherapy is given over a course of treatment, and our standard dose would be 5.5 weeks of treatment, 28 daily treatments. That's Monday to Friday. So once we've looked at the scans and decided how we give the radiotherapy, this is the tumour on the chest wall of this patient. The red area, if you can see, is where we want to treat. and then there's a radiotherapy beam coming from the front and a radiotherapy beam from the back that meets in the middle and treats this tumour.